Hi, my name is Atif Darish, professor and consultant of obstetrics and gynecology. Nowadays, we face a lot of cases with increased endometrial cavity fluids that are referred to the endoscopic units for hysteroscopic intervention. And actually, this category of patients were not seen before the interventions by the cesarean section, of course, by myomectomy and other uterine surgery, and also were not frequently seen in the normal patients or the infertile patients, but nowadays is well seen in the IVF-XZ patients. So I constructed this lecture to highlight the role of hysteroscopy. Is it essential to do hysteroscopy for all cases of endometrial cavity fluid or not? And actually, you have to know that the endometrial cavity should have some fluid. And this is natural due to the endometrial secretions, mucus, and some secretions from the fallopian tube. So the fluid seen inside the endometrial cavity by ultrasound less than 3 millimeters is considered normal, and they have to measure the endometrial cavity fluid by measuring the anteroposterior diameter of the adjacent endometrial surfaces. You don't have to include the endometrial thickness in your measurements. And this is the appearance of the endometrial cavity fluid. Here is the anteroposterior diameter, and these are transverse diameters. Some studies use the 3 dimensions to estimate the volume of this fluid. But simply you can measure the fluid by measuring the anteroposterior diameter of the endometrial surfaces. And if it is less than 3 millimeters, it's considered normal. If it is more than 3, which is 3.5 and more, this is abnormal. And actually, it is a part of what's called hydrometry, and this is a broad term that describes fluid inside the uterus. It may be clear fluid, maybe turbid fluid, maybe infected, maybe any cause. And actually, this term is commonly used in the postmenopausal women due to marked cervical stenosis and some endometrial fluid inside the uterus. So the abnormal endometrial cavity fluid is 3.5 millimeter anteroposterior diameter between the adjacent surfaces or more at the day of oocyte pickup, because this means that timing is important. When you are doing ultrasound, you have to ask your question, what is the cycle day of this patient? If this excessive endometrial cavity fluid seen at the time of oocyte or ovum pickup, this is bad because it has deleterious effect and decreases the outcome of the IVF-XZ. And here you can see the in this systematic review on 28 and more thousand and more cycles, that the size of the endometrial cavity fluid has impact, because if the size is less than 3.5, the pregnancy rate is not affected. But if it is more than 3.5, the pregnancy rate is affected. And also timing, if you see it in any time, this is not important. But at the time of embryo transfer, it leads to a decreased pregnancy rate by 26%. And the prevalence actually of this endometrial cavity fluid is variable, but may reach between 7 and 14% of cases subjected to IVF-XZ. So it is not rare. We see it in our IVF-XZ patients. So what to do in such a case? But before discussion of the management, we have to know why this fluid comes inside the endometrial cavity. This can be due to direct flow from the obstructed distended fallopian tube, which is Hydrosalpinx, or due to transudation from the endometrial tissue, like transudation or due to increased vascular permeability that is similar to the mechanism of ovarian hyperstimulation syndrome, maybe due to scarring of the uterus with retention of fluid, behind this scar of the endometrial cavity. So these are the mechanisms of occurrence of this increased fluid. And this fluid inside the endometrial cavity may interfere with implantation, increases pregnancy rate, increases incidence of cancellation rate, and increase freeze oil approach rate. And actually, it interferes with implantation by flushing the cavity, so flushing the fertilized oocyte, and has effect on the endometrial receptivity and implantation as well. What is the cause of accumulation of fluid inside the endometrial cavity more than 3.5 millimeter to be seen by ultrasound in our patients? The main cause may be uterine. Think uterus, always think uterus is the cause of accumulation of fluid. Maybe cervical stenosis, maybe adhesions in the cervix, maybe cesarean section, which is the lower part of the uterus, maybe myomectomy, maybe hysteroscopic adhesolysis, or any intrauterine adhesions. So think uterus as a cause of accumulation of this fluid. But you have to think also the fallopian tube, if it is pathologic with transudation of the fluid inside into the endometrial cavity, particularly if it is obstructed and hydrosalpinx. Also think of the ovary in some cases of polycystic ovarian syndrome, ovarian hyperstimulation syndrome, endometriosis, and endometrioma. You can find accumulation of fluid inside the endometrial cavity. And if you don't find any cause of these, you have to consider it as an unexplained factor. And in this big-sized retrospective study, they found the risk factor for developing this fluid is uterine also, as I told you, previous pelvic or endometrial surgery, cesarean section, myomectomy, ovarian like PCOS or ovarian hyperstimulation, or severe endometriosis. Okay, we see some fluid inside the endometrial cavity by frequent transvaginal ultrasound follow-up of our patients. What to do? We have to know the fact that this fluid may disappear and may persist. So if it will disappear, this is called transient endometrial cavity fluid. And this occurs in the majority of cases. In one study, more than 78% of cases, particularly if you see the patient, timing is important. If you see the patient in the early follicular phase, it may disappear at the time of ovum pickup. So if you see fluids for the first time, don't panic, don't consider it serious, particularly if you are seeing the patient in the follicular phase, and you have to follow up this fluid to see it at the time of ovum pickup. But if it is persistent, this means that there is a cause, mostly there is a cause, particularly uterine scarring, as I already mentioned too. But the transient endometrial cavity fluid usually disappears on the day of embryo transfer, and in such a case, it doesn't have any effect on the embryo implantation and clinical pregnancy rate. So timing of seeing this fluid is important. If you see the patient in the follicular phase, usually it will disappear in more than 78% of cases. But if it persists till the time of embryo transfer, you have to expect failure in more than 26% of cases, because the embryo will be flushed from the cavity by this fluid. The endometrial receptivity is affected, the implantation is affected. In addition, that this fluid may contain some organisms that may destroy and may secrete toxins that affect the implantation. So in this systematic review of 28,000 cycles, the pregnancy rate decreases by 26% of cases if it is seen or persists till the time of embryo transfer. And the predictors of persistent endometrial cavity fluid, if you see a patient with a previous scar of cesarean section, which is uterine niche, or thin endometrium at the HCG triggering day, history of hysteroscopic adhesolysis or ovarian PCOS, or treatment with GnRH antagonist, you have to expect in those patients that this fluid will persist and it is less likely to resolve spontaneously as seen in this relatively recent study. So think uterus. The uterus either infection, subclinical infection of the endometrium, or scarring of the uterus. And subclinical infection, actually it is a form of chronic endometritis, because acute endometritis is manifest as a part of PID with pain, fever, and so on. But chronic endometritis is usually asymptomatic and subclinical. And actually it is characterized by infiltration of the stroma by the plasma cells. And this is common in scarred uterus by uterine niche, myomectomy, and also in Hydrosalpinx and in endometriosis. And it has been found in one study, they took the biopsy from the uterine niche, that more than 20 to 40% of cases of the excised tissue of the uterine niche contains chronic endometritis picture by staining of the plasma cells and seeing the antibody of CD138, which is a test for plasma cell, which is plasmacyte marker. And this antibody, if seen in 10 plasma cell, shows the presence of 10 plasma cells in 20 high power field. This is subclinical endometritis. Regarding the role of hysteroscopy in diagnosing chronic endometritis, yes, it has a role. You can see abnormal pathologic endometrium with strawberry appearance, hyperemic endometrial areas flushed with white central points, or you can see micropolypi in the endometrium. And if you put stain inside the endometrial cavity, methylene blue, usually the normal endometrium, healthy endometrium, does not take the stain, and staining of the dark blue color of the pathologic endometrium. So if you put stain inside the uterus and see it by hysteroscopy, this is called chromohysteroscopy, and you can see some staining, some areas of staining. This means that these areas are diseased and affected by endometritis and apoptosis. And this finding guided us to see that the abnormal staining of the endometrium and missing staining of the some areas like fundal transverse endometrial defect or some adhesions were the key of our innovation of description of this Darush line in the fundus of the uterus, which has been recently published and cited several times. Also, you have to think uterus regarding scar, particularly uterine niche, with the frequent cesarean section prevalence all over the world, myomectomy, adhesolysis, and metroplasty as well. In cases of uterine niche, you can see this defect at the site of cesarean section, but usually you see endometrial cavity fluid, which is explained by retrograde spread of the fluid accumulated in this niche to the endometrial cavity. And this is the cause of brownish discharge on the tip of the embryo transfer catheter after embryo transfer in such cases, and this contributes to decreased pregnancy rate in those cases. And the pregnancy rate is much more lower if the patient has uterine niche due to these factors that affect success. So don't forget that in any case of uterine niche, you should look to the endometrial cavity fluid to check if it is present. The patient has two factors of failure, which is infection, chronic endometritis, accumulation of the menstrual blood here, and retrograde spread to the implantation site. And of course, in cases of uterine niche, the infertility or failure of pregnancy is attributed to the retrograde flow through the uterus, effective implantation, the obstructive sperm passage toxicity on the sperm by the retained mucus and blood, decreased mucus quality, chronic endometritis, and effective implantation. But the role of hysteroscopy in uterine niche, it has a definite role to confirm diagnosis by seeing the crescent view of the internal os, by seeing this effect between the cavity and the cervix. And this is the site of the cesarean section, seeing a pouch or discontinuity of the anterior uterine wall with retention of some blood's brownish discharge here. But hysteroscopy is not valuable in estimation of the residual myometrial thickness, which is important for decision of the line of management. If it is less than 3 millimeter, the hysteroscopy is contraindicated due to the possibility of injury of the bladder. But if it is more than 3 millimeter, you can do hysteroscopic resection. So if it is less than 3 millimeter, you have to do niche repair by laparoscopy or other approach. And this description of uterine niche is seen in this video in this channel as well. Also, you can see excessive endometrial cavity fluid after myomectomy due to possibility of scarring and retention of fluid, also after adhesions or after adhesiolysis if it is incomplete. Don't forget that cases of Hydrosalpinx, you can see endometrial cavity fluid, and this is due to this decreases fertility of those cases by direct toxic effect on sperm motility, defective endometrial receptivity, direct embryo toxicity with abnormal expression of HOXA10, which is a protein coding gene, growth factors, enzymes, peptides, steroids, and cytokines. All these factors would lead to decreased implantation and pregnancy rate with disruption of the endometrial environment. So don't forget to see the fallopian tubes by ultrasound if they are distended or not, particularly if the patient has previous pelvic surgery, previous history of PID, endometriosis, or infections. And of course, since a long time, it's well known that the miscarriage rate and decreased pregnancy rate is high in those patients with Hysteroscopy. And if you fail to see the Hydrosalpinx by ultrasound, and the patient gives positive history suggestive of Hydrosalpinx, you have to order for HSG to see them, or the 3D ultrasound you can see also, or Doppler ultrasound, or if she has a MRI or laparoscopy as well. So we have patients with uterine causes like infection or scarring, ovarian causes like PCOS, ovarian hyperstimulation, and some protocols of induction, antagonist protocols, so unexplained causes, or fallopian tube causes. What to do? We have a plethora of causes that may lead to endometrial cavity fluids. Here comes the role of precision medicine. Not all cases are treated similarly. One size fits all protocol is not suitable for endometrial cavity fluid simply because it may have a cause, but it may not have a cause. It may persist and may be transient. It may be minimal amount, maybe excessive amount, may be clear or turbid. And if it is turbid, you have to consider infection. And this is another approach and needs antibiotics and so on. And maybe in natural cycle, in normal infertility patients, or maybe IVF XZ patients. In natural cycle, usually it doesn't affect the pregnancy rate, but in IVF, if it is more than 3.5 millimeter and persistent, particularly at the time of embryo transfer, it may decrease pregnancy rate, as you already seen, by 26% cases. So all these factors contribute to individualization of management. You cannot treat all cases the same, because if the amount is less than 3 millimeter, usually it doesn't affect you. You have to ignore, you have to don't put it in your mind. It will not affect pregnancy rate, and interventions to decrease endometrial cavity fluid or to treat it have enhanced pregnancy outcome in ART cycle. So I summarize to you the lines of management of endometrial cavity fluid. You may have no treatment if it is transient and less than 3 millimeter. Expectant management if it is more than 3.5 millimeter. And causal treatment if it is persistent and more than 3.5, or aspiration or hormonal or phase all. What about expectant management, which means that you see the excessive amount, 3.5 and more, but you don't have to interfere because timing, as I told you, it is usually transient in 78% of cases, particularly if you see the patient early during stimulation. So wait until the time of HCG. Causal, because you have to treat the cause. If you have a patient with chronic endometritis, you have to give antibiotics, particularly doxycycline, as mentioned in many studies, or combination of intrauterine antibiotic and oral antibiotic intrauterine infusion and oral antibiotic therapy have more significant effect and enhancing effect on the treatment of chronic endometritis. So you have to treat. If you have a patient with uterine niche, you have to have a protocol of management, prevention, treatment, and treatment may be surgical, may be medical, and surgical may be conventional or endoscopic. And here comes the role of hysteroscopy. If it is the residual myometrial thickness is more than 3 millimeters and the defect is small, you can go to resectoscopic or lobe excision and roller ball. And here comes the role of hysteroscopy. You have to do 3 steps, not 1 step during hysteroscopic excision or correction of the distal rim. You have to use a resectoscope for a section of distal rim only. Don't you excise the proximal one to minimize the risk of cervical incompetence, and actually it is not valuable in prevention of accumulation of the menstrual blood. Number 2, to coagulate the defect and fragile vessels at the bed of the pouch and to kill the infected tissue. And of course, you have to take biopsy. And lastly, and importantly, you have to have concomitant monitoring of your procedure to avoid bladder injury by doing transabdominal ultrasound guidance done by your assistant. And here is the idea of cutting of the distal rim of the niche to avoid accumulation of blood. Proximal part is not important because if there is no distal rim, there is no pouch and no accumulation of fluid. What about hydrosalpinx? Hydrosalpinx also can be treated conservatively or radically excision of the fallopian tube, or conservatively you have to do a salpingoneostomy for keeping functional fallopian tube, or you can keep the fallopian tube but non-functioning. And here comes the role of hysteroscopic occlusion, and this hysteroscopic occlusion can be done by insertion of a tubal occlusion contraceptive device, which is Essure, and this has some disadvantages with high miscarriage rate and low clinical pregnancy rate and live birth rate due to increased fluid accumulation. And we have to do this procedure for the accumulated fluid inside the uterus. And alternatively, we described a novel technique of hysteroscopic proximal tubal occlusion published in the ACTA before around 17 years. And this means simply that you go with the roller ball electrode to inside the peritubal bulge, which is Darwin's triad, and make coagulation until char formation and what at 60 to 80%. And in such a case, you can achieve occlusion of the fallopian tube in around 64% of cases, as found in our study. Some doctors say, no, we don't need to do any surgical intervention. I'll do aspiration. Aspiration is a good option for the endometrial cavity fluid. It reduces the fluid from the cavity by introduction of embryo transfer catheter and aspirated fluid. And in some studies, it has been found to make a resolution in half of cases. Unfortunately, pregnancy rate in this group remains low, because you should consider the cause of accumulation. And this procedure is actually suitable for patients with unexplained endometrial cavity fluid and those patients with free hysteroscopy and free 2D or 3D ultrasound. Otherwise, if you do aspiration and the patient has uterine niche or hydrosalpinx, what's the value? It will reaccumulate and pregnancy rate will be low. And here is a small sample size study which makes aspiration and the time of HCG with a 50% success rate, but 5 pregnant ladies only. And another study, a small sample size study also, which compared aspiration with antibiotic for fear of chronic endometritis, which achieved better results if you do it at the time of egg collection than doing it immediately before embryo transfer. So aspiration is a good option, but provided no cause and provided that you are the fluid is clear and no evidence of infection or turbid fluid as well. Some studies reported hormonal treatment giving progesterone as anti-angiogenic drug and inhibits endometrial cell proliferation and anti-inflammatory as well. And they used it in the same ART cycle in the follicular phase, but it may have deleterious effect of endometrial receptivity. And others used progesterone prior to frozen embryo transfer until the fluid disappear, and they can do embryo transfer in such a cycle. And the last option for those patients is to do freeze-all protocol, which means that you take the oocytes, fertilize them, and keep them in the vitrification or cryopreservation. Why? To avoid until you solve this problem. If you have a cause, you have to refer hard to do the uterine niche management, Hydrosalpinx, and so on. And if it is large amount and persistent and failed hormonal or aspiration therapy, and particularly if the fluid is combined with a complex intrauterine environment like polyp, mucus, submucous myoma, or otherwise. And in this table, don't forget this table of cryopreservation indication, and based on randomized controlled trial, BGDs, and variable stimulation risk, and PCOS. And this rescue also is important for our case of endometrial cavity fluid accumulation. And this is a rescue strategy to save the embryos from dislodgement by this fluid from the endometrial cavity. Also, if you discover a Hydrosalpinx during egg retrieval or ovum pickup, you have to cancel this cycle and make cryopreservation. And this is called rescue approach in cases of late discovery of Hysteroscopic. So in conclusion, don't panic if you see endometrial cavity fluid. If it is minimal, it's usually less than 3 millimeters, insignificant. If it is transient, particularly follicular phase, don't panic as well. If it is a cause by any cause, you have to treat this cause. If aspiration, if unexplained cases, and particularly in some cases, I was putting in mind that the success rate is not too high and pregnancy rate is not too high, and hysteroscopy remains the central method for diagnosing and treating endometrial cavity fluid in all cases. So don't ignore the hysteroscopy. Don't ignore to offer your patient hysteroscopy to search for a cause, particularly chronic endometritis, hidden adhesions, or any minute or tiny lesions inside the endometrial cavity. Thank you.